Hi, everyone. This is Liz Woodruff. I'm the director of the Idaho Academy of Family Physicians. Thank you for being here today for our monthly grand rounds featuring Idaho's family medicine residencies in Idaho. Today, I'm joined by Dr. Emily Jensen at the Eastern Idaho Regional Medical Center program to discuss abnormal uterine bleeding. This event runs from 12:30 to 1:30 p.m. Mountain Time. And to receive CME for the event, please check out the chat. I'll be dropping this in throughout the presentation as people join. There's a link to a short Google form, or you can email me if you have issues with Google Forms, and we'll make sure you get your CME within the next month. Dr. Jensen will give her presentation, and you're welcome to put your questions into the chat as she speaks. Once she concludes the formal presentation, she'll be saving time for your questions so we can read them from the chat, or you can unmute at that time. And with that, I am going to turn it over to Dr. Jensen. Please take it away.
Awesome. So as you can see, I'm talking about abnormal uterine bleeding today, or AUB. And I'm just going to jump right in. So our learning objectives today, here we go. So we're going to review our normal physiology of the 6 vital sign. I had a attending tell me once that this for patients with uterus, their menstrual cycle is their 6 vital signs. So important to know it, important to memorize it to help yourself when you're treating these conditions, as well as educate your patients on what their body is trying to do every month. We're also going to review normal values for menses, how long should they last, how frequently should they occur. And then we're undergoing the pathophysiology of AUB. We're going to undergo workup and treatments for certain etiologies. And then I have a few cases to present at the end. So we're just going to jump right in. So our 6th vital sign, I know we've seen this chart multiple times, but just kind of to review so that we're all on the same page, what should be happening. The menstrual cycle is controlled mostly by estrogen, progesterone, and as that estrogen peaks, as that follicle, that dominant follicle is forming, that is going to signal your FSH and LH to spike, thus producing ovulation, and that's going to regress in the ovary to form corpus luteum, which will be responsible for progesterone until the placenta can take over. If no implantation occurs, that progesterone is going to drop off, and that's when menses begins. So, and I tell my patients about this, obviously trying to simplify it so that they understand, but pretty much know this by heart. Hopefully you do by now. Just wanted to put this up for review. But obviously any issues with this, you're going to have abnormal uterine bleeding. So we'll go over all the etiologies that can cause that in a moment. But I also like to just delve in a little bit deeper, because sometimes we get so caught up in what we're doing, we forget how amazing everything that we do is and just the function of the endometrium alone. So I always like to kind of go into a little bit of the details here. So you can see on the slide that myometrium level with the muscle of the uterus, but then we also have these 2 areas of the endometrium itself, the basalis and the functionalis. And the functionalis is the one that's going to slough off monthly. And so just kind of some cool physiology because I enjoy it. But the functionalis layer and the basalis layer differ in that the basalis arteries should be insensitive to the hormonal changes. And we jump into progesterone specifically. So when progesterone is mounting up with the corpus luteum, there are anti-inflammatory properties that progesterone is responsible for to help maintain a pregnancy, but also to make sure that our endometrium doesn't slough off early, right? And so once that does start to kind of go on the downhill and start kind of regressing because no implantation happens, that tissue factor and plasminogen activator inhibitor, that receptor will drop with withdrawal. So that's going to cause us to lose our hemostasis, and that's going to raise your concentrations of COX-2, raise your prostaglandin synthesis, and then those spiral arteries are going to constrict, and then that's going to cause kind of the death of that tissue and the sloughing off of it. So that's kind of what's going on at a very cellular level. And I put this in just for your big dysregulation of this process can lead to abnormal uterine bleeding and greater blood loss. So just keep that in mind. And then, of course, we all memorize this like millions of times, but any issues in the coagulation pathway can be a cause of abnormal uterine bleeding, as we will talk about in a little bit. So there's your reminder there. So let's jump into the next learning objective, which is our normal values. So based off what source you use to look this up, it can vary. So pardon me, let me mute my phone. So 21 to 35 days is kind of your typical like length total from day one of menstrual bleeding all the way down to when you're done with the period, and then after ovulation the next cycle begins. So there's some little variation there, and we'll go into how many days it should vary. But if you're less than 21 days, you can say that that's frequent bleeding. If it's greater than 35, based again on your resource, it can be infrequent. And then if you've gone 3 months without a period, that's when you say that they have amenorrhea. So blood loss volume. So being someone with a uterus myself, it's hard to measure this, but 50 to 80 milliliters is usually what you expect to lose. If it's less than that, it's light. If it's greater than that, it's heavy. Now, if your patients do use menstrual cups, they do have, depending how comfortable your patient is, some girls get grossed out by it, but there is actually little like marks inside the menstrual cup to measure specifics. But don't fear, I have some cool little pictographs to help you kind of get a better idea in the following slides. And then how long should it be lasting? So you want it to be less than or equal to 8 days. If it's greater than that, then you'd consider that to be a prolonged menses. And then kind of the regularity should be like from start to cycle to end of cycle. It shouldn't vary than greater than 9 days. So if they're like getting variations like, oh yeah, I have my period every 21 days, and then the next month it's every 35 days, like that would be irregular. So they should have it regular. Also, just a side note, like there are so many cool apps. So any patient that you should be talking to about their menses, which all of my female patients or patients with the uterus, I do ask them about this because it is important. And so I tell them about the apps they can get so that they can have that data to show me, because it helps all of us out to understand what's going on. So plenty of apps out there. The one I recommend is Flow, F-L-O. It's very awesome. They can keep track of all of their symptoms and then how long everything's lasting. And it really like summarizes it really neatly for you. Okay, and then of course, any abnormality in these, AUB. And then obviously there's acute or chronic. Chronic usually has been happening for about 6 months of irregular periods or variations in anything we just talked about. So additional clues that they have abnormal uterine bleeding. So what if your patient has a hemoglobin less than 12? So it raises your chances of identifying, but if they do have normal hemoglobin levels, it doesn't exclude it, because perhaps they're having more of an acute menses that heavier, and obviously like that can take a while for the body to catch up on that, or their body's been able to keep up on it. Okay, so you can't just base it off of that. As far as like clots, when your patient says, yeah, I passed clots, which one should be concerning for you? According to the source that I like to use, which is Williams Gynecology, greater than 1 inch diameter. And I don't know if anybody else is weird, but I love OB, so I measure everything with my fingers and like my cervix checks. So 1 inch is 2.5 centimeters. So if you're passing clots greater than that, then you should be concerned as well that there's an issue that you should work up. And then how many pads is concerning. If they're changing saturated, and that's the key there, saturated pads, like greater than every 3 hours. Because some of my patients specifically will be like, oh yeah, I'm like changing my pad every hour. And then you have to ask, well, how like saturated are they? And they're like, oh, well, just a tiny bit, so you got to make sure that don't just go back off of that. Make sure you're quantifying how much blood's actually on there. And then these charts, which I haven't used, but when I was producing this lecture, they're kind of interesting. So these are different charts that people have made up over the years, and it can be kind of nice for your patient to kind of track on them. So there's obviously like 5 different options here, but it helps them kind of circle like what kind of does your pads look like on E, and like they can track a lot of different things. So you can, the name of these are pictorial blood assessment charts, or PBACs. If you find like that would be useful for your patients to help you understand how much they're actually bleeding. And there's different scoring for each of these so that you can understand kind of how much blood they're actually losing with their menstrual cycle every month. So moving forward, let's go ahead and talk about kind of etiology and pathophys. So hopefully you automatically think of palm, Cohen, or coin, however you want to pronounce it. But structural palm, you can just remember like your palm itself is structural. So PALM. Hopefully I know we don't have like our audio on right now, but so P, think what P is, and you have this nice picture to kind of tell you, but we got polyps, we got adenomyosis, leiomyomas or fibromas, which can be in different positions depending where they are in the uterus layers. And then you have malignancy. So that's your palm. And obviously structural. So this is going to be, I don't go into this as much because imaging will usually help point you to this etiology. And we're going to talk about workups for this abnormal uterine bleeding as well. And then we come to our non-structural causes. So C, if you guys remember that, there's a little picture that helps you, coagulopathy. And then ovulatory dysfunctions, the next one, E for endometrial, I for iatrogenic, and then N for not yet classified. And so a couple years ago, I should put the specific year in here, but we did kind of transition from using like menorrhagia or metorrhagia, those kinds of forms. And it's kind of trying to be a push towards this kind of classification you see. I don't know if you can see our mouse, but once you do find the reason for it, like your ICD-10 code is going to be AUBP for polyp. And you can obviously put chronic or acute based on how long they've been having the bleeding. But once you find an etiology, it's AUB with one of these identifiers from the palm Cohen. So because structural is kind of straightforward, I wanted to focus more on the non-structural causes. So jumping right into that. So coagulopathy, you can think of all the different etiologies that can lead to any issues with the body's ability to coagulate. So it can have an inherited coagulopathy, like we talked about the coagulation cascade, but liver failure is a big one. And I bold this because I did have a patient in clinic who presented with very, very heavy menses, like bleeding through everything, even her clothing. And she did have pretty progressed cirrhosis. And so she wasn't jaundiced and she was just swollen. So heavy menses and swollen. And then further workup showed that she did indeed have cirrhosis from her heavy drinking. But just remembering like anything that can affect the production of coagulation factors as well can affect menses in our patients. And then you have immunologic and then certain medications, which we'll go over, but specifically because of coagulopathy, they have heart failure, history of stroke or MI, and they're taking aspirin, or if they have a clotting disorder and they're on different anticoagulants, you need to keep that in mind as well. So something to be aware of when you're asking history and kind of getting more information. And then ovulatory is kind of a large list, but obviously depends on the patient's age is kind of how you kind of rule this one out. So obviously if they're an adolescent, HPO immaturity, you expect them to have a couple years of irregular periods and let them know that. Once they start their period as an adolescent, it'll take a couple of years for their body to kind of work it out, and they should eventually be regular about 2 to 4 years after they start their period. But then when you get into perimenopausal and menopausal, you're going to have that follicle aging that kind of leads to irregular distribution of that estrogen progesterone balance that the body needs to have. Then you can have premature ovarian failure and then these androgen excesses through these different etiologies that we can work up as well. And then the thyroid, we all know to check a thyroid when anybody's having these issues because that can mess up things as well. Then obesity is a big one as well. I see this often with the PCOS patients as well, but obesity, because of that adipose tissue creating more estrogen, it can lead to these kind of irregular cycles as well. And then anything that's going to mess with your prolactin levels as well, keeping in mind the physiological changes that can happen, but also medications, which is under another category. But then we can also have HPO dysregulation. Has your patient been under extreme stress? Are they eating less? Are they exercising extreme? And then even if they work like night shifts and stuff, that can kind of mess up things a little bit with how their body's functioning in general. So that's kind of the ovulatory category. And then we jump into the endometrial. So you can have atrophy, you can have this intrinsic abnormality where things just aren't forming well, endometrial hyperplasia, because of the excess estrogen that they're endometrial linings exposed to. And then you can have chronic endometritis, which is kind of an interesting one, kind of hard to work up and more kind of a, what's the word? Kind of you rule out clinically by other means. So, and then also like keeping in mind, like had this patient ever had a history of a DNC? Was that kind of too aggressive and kind of sloughed off too much of that, those layers that I showed you on that histology slide, so that we're not kind of producing healthy endometrial tissue there. And then we have iatrogenic, so birth control. Make sure that when you're talking to your patient that you don't forget to ask them about birth control, because that one obviously, depot shots, even the IUDs, even the next one on, like they can mess with your period. So if you forget that question, you might go down a whole line of stuff and then it'll come up later and you'll be like, oh my goodness, well, it's a side effect of likely your birth control. We should probably take it out or remove it and get you on something else to see if that's the main cause, right? And then medications, keeping in mind like all of these, even valproate, which is a common one that some people are on for seizure disorders, that can mess with your ability to coagulate. It does some weird stuff to the blood and production. It can even affect your bone marrow. So being aware of these different drugs and how they interact. And then like your antipsychotics, anything that's going to allow more prolactin to be in your system can mess with your period as well. So continuing, not otherwise specified. So this one's kind of big, but you think about infections. So do they have pelvic inflammatory disease, cervicitis, tuberculosis, and then arterial venous malformation, kind of with like those DNCs, did things just not go well? There's a lot of different reasons for things to happen in the pregnancy and then during delivery, lots of complications. And then other, I know malignancies in there, but like think of malignancy elsewhere in the body, not just like cervical, because that would be more structural, right? So patient has an undiagnosed cancer elsewhere that can be messing with their period. Think about trauma, make sure that you're evaluating patient safety, making sure that they are treated well by their partners, their spouses, there's nothing going on there, and make sure there's no foreign bodies stuck up there as well. And then you can get these outlet obstructions. You can get post-surgical granulation tissue that's coming out, especially women that even have like a hysterectomy. And then they kind of have that vaginal cuff, that granulation tissue is kind of coming through, and you need to go in the office and kind of burn that out instead of working up some other kind of thing. So that one's kind of just more on your inspection. And then your prolapse fallopian tubes. I've never seen one, but it was in there and I was like, that's an interesting one. And then you have vaginal adenosis. So there you go. And then obviously you want to make sure when you're getting all of this information, you're asking all these questions. What age did they start? What's the date of your last menstrual period? Your birth control, timing, amount of bleeding, kind of going through all of those things, getting their family history, meds. And then I put herbal supplements on here because we live in a world where people don't necessarily trust doctors anymore. They trust TikTok and all kinds of stuff. And so as a provider, it's important to be educated on things, even whether or not you believe in it, your patient does for whatever reason. So here's a list of some of them that can actually affect your menstrual cycle, especially St. John wort. Some patients are on that for depression. And then I just put this in here. This is a free app that I use frequently, and I really like it because it actually has articles and research to support like the side effects and the mechanism of action about these different herbal supplements that a lot of my patients are on. So I just want to put that out there. If you wanted to download it, it's a pretty cool app. You can just pull it up right when your patient's talking about it and just like see side effects and different things and see if it interferes with medications they're on. So it's a pretty helpful tool to have in your phone. Okay, so speaking more in with AUB and kind of going into how do you start like working this up in your head while you're getting information. So obviously, are they adolescent or post-adolescent? Because that's going to affect the etiology. So we talked about like that HPO axis, and if it's mature enough to be having regular cycles, this is where your kind of coagulation defects are going to come in. And then they can have benign. Benign is most likely in adolescence versus malignant neoplastic growths, but you always want to rule out pregnancy, sexual abuse, and STDs as well. Versus post-adolescence, you're thinking more pregnancy, STDs, leiomyomas, adenomyosis, and endometrial polyps. So based off of their age alone, you should be able to kind of start categorizing categorizing in your head which of these might be occurring so you can work up more effectively and efficiently for yourself. And then kind of with increasing age, you think more estrogen exposure. So then that kind of leads to these kind of things. So thinking less pregnancy, but not necessarily ruled out, especially if they haven't had like a prolonged period where you've actually diagnosed menopause. And then the malignant potential is kind of rising for this population of patients. And then kind of your main evaluation goal with postmenopausal patients is to rule out cancer. So pregnancy, obviously it can be really common. So 15 to 20% based off the source I was looking at can have some bleeding with their pregnancy. And obviously most of them are concerned with early miscarriage or abortion, ectopic pregnancy. So you want to make sure that you work this up to help give them peace of mind, because it can cause severe distress for the mother, especially if they've experienced loss before. But then you also want to think of other etiologies, less gestational trophoblastic disease, cervical eversion, and polyps as well, because those can present during pregnancy, just like at any other time. Okay, so you worked up, you've got your history, you've got some etiologies in your head. So what kind of physical exam and lab should you do? Well, bam, first you should get a pregnancy test. All reproductive patients with a uterus, always rule that out first. And then you kind of work up kind of all of these etiologies based on what you are thinking. But kind of coagulation, thyroid, prolactin levels, you want to confirm the bleeding site. So if your patient is willing, please do a gynecological exam, check that the bleeding is actually coming from the vagina versus the urethra or the rectum. And then you want to do the swabs to rule out infection, update their PAP to get that cytology. And then make sure, so endometrial biopsy is a question. So according to ACOG, in their clinical, I forget what they call them, but from 2016, they recommend any woman greater than 45 years old with abnormal bleeding should get one, or if they're younger than 45 with a failed initial medical management, persistent, and they have a history of some source of unopposed estrogen. So that's ACOG's recommendations. And then obviously sonogram, sending them for a vaginal ultrasound is a good idea as well to rule out those structural causes. So obviously endometrial biopsy, I put a link in here for you to use, but by now maybe you've done one, maybe not, but here's kind of the list. You do the pregnancy test. I always have my patients take like 600 to 800 NSAIDs before they come in, because it can be kind of painful and crampy. Then you space your speculum, you clean off the cervix, you use a single tooth tenaculum to straighten out the cervix, and then you advance the pipette, and we use the plastic ones in our clinic, and you sound your uterus, and then you do kind of a 360 degrees around to collect enough tissue to send off. And if this fails, you'd want to do a DNC for sufficient sampling, send a guide to do that. And then just a reminder that just because you had a negative result does not definitively exclude cancer. They could be in the very early stages of cancer, and perhaps you just missed the one area in their uterus that was actually abnormal. So just know that it's not 100%. You could have a biopsy with normal tissue, but abnormal uterine bleeding if it continues, or if you have a higher suspicious, get that further sampling, send them for a DNC and get a good peace of mind with your sample. Okay, as far as transvaginal ultrasound goes, you can get this if you suspect one of the structural causes from the palm, right? So as far as endometrial thickness goes, if you have like a global pathology or a focal lesion you're suspicious for, you can send them to a gyne to do kind of a hysteroscopy and do that saline infusion sonogram and get kind of a better picture of what's going on there. But most of the time, is if they're premenopausal, it's hard to tell what's normal or abnormal based on where they are in their cycle, which is hard to tell if they've been having abnormal uterine bleeding, inconsistent cycles. But as far as postmenopausal, if they're having abnormal uterine bleeding, that endometrial thickness, based on the source I used, I know some people say 5 millimeters, but if it's greater than 4 to 5 millimeters, that's suspicious for endometrial cancer or some abnormal tissues there. If they're not having abnormal uterine bleeding, then greater than 11 millimeters. An asymptomatic woman should be get a biopsy on that. And then you can follow up with other further imaging studies if it persists. But yeah, as far as like a consensus for when to do an endometrial biopsy, I kind of go back to this ACOG recommendation and do it based off of that. Okay, so then like, as you can see, like the thickness is going to change versus if you're menstruating currently or if you're kind of in that proliferative phase. So it's kind of what it looks like on ultrasound. If you do your own ultrasounds, I don't know if anybody's trained here to do that. But yeah, you probably know better than I do about what you're looking for because I'm not trained in this. I send these out and have them read by a radiologist. So let's jump into some cases. I think we're doing okay on time. In these cases, this first one especially, there's a lot of info, but just to help you kind of think through things a little bit. So you have a 62-year-old female with vaginal bleeding right off the bat. 62-year-old female, she's more on that later end of the spectrum. So kind of malignancy and those kinds of things are kind of higher on your differential. So she doesn't have any chronic medical conditions, but she doesn't see a doctor regularly. Her last visit was over 15 years ago. She doesn't have any family history of bleeding disorders or cancers, but she does have a BMI that's 38. As far as her period, her menstrual history, she stopped having periods 10 years ago, but she started at age 14. And once they regulated, she had them for 5 days with no heavy clots or bleeding until now. So she's passing heavy clots, she's bleeding. She never had any kids. She's a G0 and she's never had a PAP. She doesn't like doctors and she's not currently sexually active and she's never used birth control. So she doesn't have a history of ablation or abdominal surgery. She's not on any NSAIDs, anticoagulation medications, or hormonal replacement, but she does take St. John's wort for depression. And for the past 2 years, she's been binge drinking vodka weekly. She does not see a PCP regularly. And like I mentioned before, her last visit was 15, maybe years ago. But she's been having this consistent painless bleeding going on. And she's going through about 2 to 3 moderately saturated pads a day. So nothing too crazy and no large clots. So kind of smaller clots. So kind of things that should kind of stick out to you. So overweight, we talked about obesity kind of causing more estrogen to be in the body, especially when she's been menopausal. So her endometrial lining kind of had excess estrogen exposure. The St. John's wort could be contributing a little bit. When people say they binge drink vodka, like how much, and has it really been 2 years? So is there an alcohol component to this? Liver damage? Your last doctor's visit, she's not up to date with her cancer screenings. And then painless. So if it was painful, not necessarily saying that it would rule out more structural, but like usually when women have fibroids and those kinds of things, their menses are painful because there's something that's just not contracting the same way as everything else. So those are kind of the things, and painless bleeding is kind of concerning. So as you're thinking about this patient, I added this on, but so this one does have, so St. John wort can increase your PT time. So it does kind of mess up with your coagulation cascade a little bit. So then here's just a reminder, ask all these questions. What's your menstrual history? Make sure you're getting this information from your patients. And then here's a reminder of our Palm Cohen. Hopefully you got it down. So kind of thinking with this patient, structural causes first, and then kind of that workup we went through, right? So what's your differential? What are you thinking about with this patient? Be thinking about that. So you do the labs, you do a PAP, you do a transvaginal ultrasound, and she shows this. So 4.74, which is greater than 4, which is the resource I use personally. So we went ahead and do an endometrial biopsy of this tissue, and you got endometrial hyperplasia without atypia. So what is your treatment with that? Kind of what is your go-to with that? So basically progesterone. So you can get her on an oral, you can get her on a depot, you can get her on an IUD. And then kind of recommendations as far as your endometrial biopsies go. So you can get results of hyperplasia and intraepithelial neoplasia. So there's a spectrum of these different architectural changes in cytology that the pathologist goes over. So in this green zone, which is what our patient was, like at the very far left meaning like less crazy or less concerning is their disordered proliferative endometrium, or DPE. That's a result you can get. And that one's very much in the green zone. But once you start transitioning to this endometrial hyperplasia without atypia, they recommend that you retest after 3 to 6 months. You want to consider long-term progestin therapy because the relapses are high. And then you want to make sure that you're correcting for underlying causes of unopposed estrogen. So for this patient in particular, since her labs looked well, getting her working on some weight loss, kind of some dietary lifestyle changes. And then after the endometrial hyperplasia without atypia, you kind of enter this red zone where you have endometrial intraepithelial neoplasia, EIN, and then endometrial cancer. So if you hit the red zone, you want to send them to the specialist. But green zone, in my opinion, is something that you could still, if you're comfortable with it, continue to treat. Okay, so what if this patient was on an anticoagulant? Kind of what is the thoughts on when to stop or what kind of to do moving forward? So you want to ask them about recent dose changes or other medications they're on to see if you have anything that's messing up with the ability of that medication to be working, kind of overworking and causing the bleeding. You want to check to see if there's excess anticoagulant activity, which if they're on warfarin or something like that, hopefully they're already doing. But if they are on chronic anticoagulant and they're having this AUB, obviously you can do the daily progesterone. And this TXA contraindicated. Some providers, especially like some different podcasts I listen to, some providers will still do TXA because there's a theoretical risk of a VTE. So it depends kind of how you feel about that. But some people will treat this with TXA. Obviously, you can send that patient in for endometrial ablation and hysterectomy to just help them be done with that. One less thing to worry about, in my opinion. But if there's acute severe heavy menstrual bleeding, which is what HMB is, then you can consider reverse anticoagulation, Foley balloon to tampen out the bleed. Obviously, this is kind of more for like urgent care setting or kind of ER setting if they're just kind of having this acute issue. So what if patient had liver disease? Like what do you do? What can you do? What's okay to do? So we know that everybody kind of with like liver, like a cirrhotic patient, everything has hyperestrogenism to begin with, and that can cause this disorder, proliferative hyperplastic endometrium. And so you can think about if there's thrombocytopenia associated with portal hypertension and splenomegaly. Otherwise, their liver is not producing the coagulation factors that they need. So if they're already on an estrogen-containing product, some sources say it's okay to continue that, but then you can also switch them over to a progesterone only. But if it is severe, they do have decompensated cirrhosis, you want to avoid all hormonal contraception and then consider endometrial ablation. Because obviously not all these patients are candidates for surgery for a hysterectomy or anything like that. So more kind of symptom control with most of them. Then kind of to throw this in here. So here you see a tumor that's protruding into the endometrial cavity. And what SERM do you think has been leaked to hyperplasia, polyps, and adenocarcinoma of the endometrium and to uterine sarcomas? If you thought of tamoxifen, you are correct. So then people ask, well, if a woman's on tamoxifen and they're not having AUB, should I be screening them with transvaginal ultrasound or endometrial biopsy? No, no, no. So they've looked at that and it doesn't really change. So just make sure that if someone is on tamoxifen, you don't have to be taking extra precautions with putting them through these extra testing. They don't recommend that. So just a side note with that. Okay. So with this endometrium, because that's what this patient specifically had, kind of going into more details. So if you diagnose your patient with AUB, endometrium source, you can do the IUD, and that's actually I kind of put them in as like the most effective to the least effective. So that one works by making the endometrium atrophy. And so you see a reduction after 3 months use. Again, like make sure whenever you're doing contraception with your patients that you're letting them know that there is irregular bleeding till things kind of regulate. And for the IUD, it's about 3 months. Combined oral contraceptions also going to work on atrophying that endometrium. The blood loss is pretty good. And that one, in addition, might reduce dysmenorrhea or painful cramping. But the side effect of that one is that can make you moody and bloated. And I know some providers don't believe that combined oral contraception can cause changes in moods, but patients say otherwise, so just listen to them. So that's a reported side effect of that. And then some patients or providers will treat with TXA. So they usually do 2 650 milligram tablets 3 times a day for a max of 5 days during their period. So that's an option, and that works from the antifibrinolytic effects. And then obviously some women who don't want to do any of that, just put them on NSAIDs. And those are some options above for you kind of listed out, but that's going to decrease that prostaglandin, which I kind of talked about on that slide with the histology. But there's a role of pathogenesis of endometrial dysfunction related to that. So the reduction in bleeding is not as impressive as these other options. But remember that women will lose 90% of their blood within the first 3 days of their cycle. So you want to initiate NSAIDs prior to their menses and continue through the duration of menses. And obviously, if they don't really care to have children again, if they're kind of done with that time in their life, you can do DNC, ablation, send them for a hysterectomy even. So next case. This was a patient I had at clinic, 38-year-old female with abnormal uterine bleeding. She had an IUD for 2 years duration, and she had been on the IUD multiple times between each of her kids. She had 4 vaginal deliveries, but she came to me having cramping and spotting intermittently, and workup was negative for everything else. Her ultrasound was negative. This one's kind of was tricky for me because I wasn't getting much answers. And then we started reading up about this kind of chronic endometritis. So this one was kind of for me, kind of a process of elimination, eliminating all the other things. She had no abnormalities on her pap, everything else. So this is kind of the treatment that we did for her, but other things that you can consider as a differential. With this patient in particular, does she have a polyp? Should we remove the IUD? Her STD was negative. We went ahead and also removed the IUD, treated her for chronic endometritis, and she continued to bleed. So she ended up getting a hysterectomy because she was done with her childbearing and ready to just be done with the bleeding and the pain. But chronic endometritis is difficult to diagnose. Resources say it's kind of idiopathic is the most common cause, and some women have no symptoms. When I took a contraception elective in medical school, my 4th year, some providers believe that like chronic endometritis can kind of also be suspected if your patient has like near the end of their bleeding, like a couple days of just brown. Just kind of means like this, like kind of slower, kind of yucky kind of discharge that's just brown. They're done with their bright red bleeding. So some people think that that can be a symptom of it as well. But physical exam can also show uterine tenderness or cervical motion tenderness. So this one's kind of, I put this on here because it's kind of a difficult diagnosis, kind of a elimination diagnosis, but keep it in your mind. And then kind of like going into our pregnancy scene here, you have a 25-year-old, she went P1, she delivered about 24 hours prior at 39 weeks, 4 days. No chronic medical conditions. She had a normal pregnancy. Delivery was uncomplicated, except you had some retained placenta. You delivered the placenta and there was a little chunk still in there. So you got that out right away. But she didn't have any crazy bleeding or anything like that. But this morning, when you're doing your rounds, her temp is 39 degrees. She's having abdominal tenderness and she's tacky with malodorous vaginal discharge, and her UA is negative for UTI. She doesn't have a cough. Her STD panel is negative with her 36-week labs. So with this, you think of kind of more of an acute endometritis pictures, hopefully what you go off of. And I just want to kind of put treatment in here. So she didn't have GBS. You're going to treat with Clinda and Gent. Gent, based on the resource that I use, they prefer the Q24-hour dosing, but if you're wanting to do the Q8 dosing, I put that in as well. If their GBS is present or you don't know, then you're going to add AMP to your Clinda and Gent or have them on Unison. And then if their treatment's effective in the first 24 to 48 hours, you're going to continue that until they don't have any tenderness and they're febrile for 24 to 48 hours. But if it's ineffective, you're going to have to start looking for other sources of infection. So I just kind of wanted to get kind of that spectrum of acute endometritis versus chronic endometritis and how kind of different presentations of those. So that kind of concludes most of what I wanted to cover. So here's our learning objectives. Hopefully now you have a better kind of recollection if you needed a little refresher on that sixth vital sign of what's going on physiologically with menses. Hopefully you have a better idea of what kind of normal values to expect for menses, the pathophysiology of AUB, workup and treatment. And then hopefully those cases were kind of a good jogger of our memories with differentials and kind of what to work up. So those are my references that I use. Just to put it out there, I really enjoy this podcast called Creogs Over Coffee. It's what OBGYN residents use in preparation for their creogs, but they have some really good topics if you ever need kind of a refresher. It's really good. It's run by 2 MFM docs. And yeah, I also like curbsiders as well. Okay, so questions about anything? Now I kind of ended a little bit, but we have time for questions if anyone has any.
Thank you, Dr. Jensen. Please feel free to put your questions in the chat or unmute to ask Dr. Jensen directly. We just have a thank you from Dr. Brittany Burns. Anybody with any questions? Another thank you from Dr. Davis. I have, thank you again, Dr. Jensen. I've dropped into the chat again. If you want CME for this event, you need to fill out the Google form or just send me an email. Also, Dr. Bean had asked during the presentation whether there would be access to the presentation. I do have the presentation from Dr. Jensen, and when I send the certificates around sometime in the next 4 weeks, you'll receive that, and we'll be sure that this recording is in our CME learning library. The next grand rounds is on Monday, September 9th, same time, 12:30 p.m. Mountain Time, and that's with Full Circle Health Caldwell. I don't yet have a topic or speaker, but I will be updating you all over email on that. Final call for questions or comments? And otherwise, Dr. Jensen, is there anything else you'd like to share?
No, thank you.
All right. Well, thanks everyone for being here. We hope to see you again on September 9th. Have a great day.